Now our next session for Dr. Ajit Brindhaban. Size-specific dose estimate using Scout View in CT. Welcome, Dr. Ajit, again.
Thank you. Thank you. Can we get the screen going? Yeah. Okay. Thank you for turning up. So the title for this one is Size-specific dose estimates from Scout View in high-resolution chest CT. So in the last session I had, we talked about why we need alternative to CTDI volume and how we can actually manage individual patient doses, or how we can assess. And the AAPM recommendation is the size-specific dose estimates as it currently is used. So just to tie to the previous one, it is CTDI volume that your CT scanner gives after you set your scans, and then you multiply that by some sort of conversion factor or a size-specific coefficient, and the coefficients are based on actual patient sizes. So the benefit is that you account for patient size differences in estimating radiation exposure, but you still have to understand that the limitations that CTDI volume has also applies to this one. It only sort of removes one of the limitations. So it's a step better than just the CTDI volume. So your CT scanner gives you a CTDI volume when you plan your scan, and you can take that, and then you always do a Scout View before you plan your scan. So that's what we're trying to use in that aspect. So the conversion factors are given in published tables, so it's fairly easy to find. So the AAPM has published 3 publications. The report 204 tells you how we can actually estimate size-specific dose estimates for pediatric and adult body examinations. If you go to the back of their report, there is a table or a set of tables that will tell you what the conversion factors should be based on patient size measurements. So they do different patient size measurements. They do lateral size, AP size. Sometimes they use lateral plus AP, and they also do effective diameters, and so on. So this is the initial thing that came out based on a 32 centimeter phantom used for measuring your CTDI volume. So you can see how as your patient size increases, your conversion factor decreases, so actually your size-specific dose estimate will decrease for a given CTDI volume that your X-ray tube actually puts out. Now, these measurements, AAPM recommends that you do from axial images. There's a reason for that, but that means you can only estimate them after the scan is complete. The second publication is the report number 2020, came out in 2014. It's about using water equivalent diameter. So this particular method takes into account the tissue characteristics of the patient, how well the tissue attenuates the X-ray beam. And these are ideally the best method to estimate size-specific dose estimates. And then the last one was in 2019 for head CT examinations. So how do we work these things? So your AP and lateral measurements you can get from an axial image, and then working on either, if you combine the two for a 45 centimeter lateral and AP size, your weight of 45 kilograms, your conversion factor is 1.65. So if your CTDI volume, your CT scanner says is 10 milligray, the patient actually receives 16.5 milligrays, and that's the conversion factor does. It tells you because of the patient size, how much more or how much less than what the CT scanner reports is given to the patient. If you go to a large patient with the same CT-DI volume your machine gives, they only get 8.5 because your conversion factor is 0.85. So as you increase your sizes of the patient for the given CT-DI volume, you decrease the size-specific dose estimates. And this gives us a better representation of how much radiation the patient gets exposed to. In order for us to use that, we need to be very careful about how we position the patient. So here comes the importance of patient positioning. Because if you don't position the patient at the isocenter, if you bring the patient close to the X-ray tube, the system assumes that the patient is large because the projected size of the patient in the detectors is much larger than if the patient was at the isocenter. And therefore, if you use automatic exposure controls, it's going to create problems for the system. So even if we want to do size-specific dose estimates, you need to make sure that your patient positioning is accurate. Otherwise, your estimation is not going to be correct. So that's one thing. The difference between positioning a patient close to the tube and further away can be about 50%. So in this case, if you position the patient very close to the X-ray tube, as close as you can take, would measure a lateral width of about 39 centimeters. If you take the patient as further away from the X-ray tube as possible, then the system measures their width as 23 centimeters. Therefore, your size-specific dose estimates accuracy depends on how you position the patient, in addition to the measurements. So we did a study on size-specific dose estimates calculated from scan projection radiographs, your SCOUT view. The major problem with AAPM's recommendation is that you can only do this after you have done your scan. So even if you want to do water equivalent diameter, you can only do it after you have finished your scan. So it might be useful if we have an estimate before we actually start the scan. So we thought, what if we compare the size-specific dose estimates from water equivalent diameter to size-specific dose estimates from either lateral width or AP size from your SCOUT view, because your SCOUT view is available before your scan is done, and therefore you can make an informed justification process. So the aim was to compare size-specific dose estimates from water equivalent diameter to size-specific dose estimates from SCOUT view measurements. So what we did was patient size and water equivalent diameter based size-specific dose estimates can only be calculated after your scan is completed. So in order to facilitate a better risk-benefit analysis, it'll be better to have something that we can do before the scan is done. So we chose high-resolution chest CT because it is a large matrix imaging process, thin slices, so it actually delivers much higher radiation dose than standard resolution CT scans. So we wanted to look at what the difference would be and whether we can use size-specific dose estimates from SCOUT view. The study was done on a Siemens Somatom Definition Plus. So we looked at about 75 patient image files who underwent high-resolution chest CT. We had an exclusion criteria. If the patient had contrast media based imaging in the previous week, we excluded those because they changed the way in which your X-rays are attenuated, so we don't get the sort of correct values. So based on that, so patient size measurements, radiation dose quantities, such as CTDI volume, DLP, the scan range, and they were extracted from the image files. And then size-specific dose estimate for each patient was calculated using lateral measurement in the axial scan, the water equivalent diameter, and the lateral width from your scan projection radiograph or your scout. So if you do a PA or AP scout, you can only measure the lateral width. So these images were acquired using a AP or PA scout view, and therefore we only had access to the lateral width. So in order to calculate water equivalent diameter, what you have to do is you have to do a region of interest covering the entire patient's cross-sectional region, the skin margin, and get an average CT number and a region of interest in terms of centimeter squared or millimeter squared. And you work with the average CT number in your ROI. That tells you the average attenuation of the patient. And then because your CT numbers are scaled, you do the simple descaling and then multiply by the area of your ROI, and you get the water equivalent diameter. This is fairly established equation. You can get that from AAPM reports that you have. So in terms of comparison, we looked at size-specific dose estimates from your scan projection radiograph, labeled subscript R, and size-specific dose estimate using DW using subscript W. So we compared those two as to how close this measurement was to this one. So we did that so that because of the number of patients, the normal distribution of the data wasn't guaranteed, and therefore we did Wilcoxon test for comparing the size measurement difference from the scout view and the axial image, and then also the size-specific dose estimates from the two size measurements. We also looked at some correlations as to how the dosimetry quantities like CTDI, volume, DLP, and the size-specific dose estimates sort of correlated against lateral width measured from the patient scout and the axial image. And the significance levels were set at 0.05. Now, coming to the results. So this is just the patient demographics and the scan parameters and the CTDI volumes and DLPs. So the average age of the patient was 55 with a range of about 20 to 82. So we looked at a wide range of patients. The scan range was also reasonably widespread. The CTDI volume ranged between 5 and about 18, and the DLP from about 170 to about 570. So it's a wide range of values that we tested. So we wanted to see how well it is in this end and how well it sort of predicts at the other end. So table 2 talks about the comparisons. So the lateral width from the axial image had a median value of about 357 millimeters, whereas from the scout view, it's about 389. So the scout view kind of overestimates the patient's width, which kind of indicates that your size-specific dose estimates also are going to be slightly lower. So this is probably because your axial images are edge-enhanced, and so it's easier to find skin margin, whereas your scout view is not edge-enhanced, and therefore it's a little bit blurry around the edges, and therefore there's a little bit of uncertainty in measuring the lateral width of the patient. The water equivalent diameter was about 250 millimeters. The comparison here is that 12.9 is the size-specific dose estimate with water equivalent diameter compared to 11.6 from the scout view. That means there's a larger size measurement from the scout view, sort of creates a smaller size-specific dose estimate. But these are fairly close. When we correlated the two size-specific dose estimate values, it gave us a reasonable correlation coefficient, about 0.587, but it was statistically significant. And the size measurements were also significantly correlated with a reasonable correlation coefficient. So that means you can actually predict what the size-specific dose estimate from water equivalent diameter will be before you do the scan, because we can actually correlate the two reasonably well. The other correlations that we did were how the dosimetry quantities correlated with sizes. So this is the lateral thing from the scout view. This is the water equivalent diameter, and this is the axial image lateral view. So these indicate significance. The 3 stars mean it's not significantly correlated, but 1 and 2 stars are. So the 2 stars are correlated at a 0.001 level. And looking at the correlation coefficients, you can see how these ones, the lateral view, lateral size from the scout has reasonably good correlation coefficients. That means these are reasonably correlated. And therefore, we can actually predict the size-specific dose estimates, what the patient would get from your scout view. So this is something that you might be able to use before you do your scans. The tables are available. You can download them. It's available freely, and then use them if you think that they might be useful. So to finally conclude, so SSDR, so the size-specific dose estimates from your scan projection radiograph, correlates well with your water equivalent diameter ones. Now, the water equivalent diameter was estimated from the middle slice of the scan, and therefore they actually are sort of average sort of values. So you can use them to estimate radiation dose to the patient, but you need to understand the difference could be probably around 20% at most. This one looks like about 10% in the median, but if you look at the range at the higher end, you have about 20% difference. So you can actually estimate within about 20% of the actual sort of values that you may get if you use the water equivalent diameter. So they represent more realistic CTDI values for your individual patients, but we probably need to do further imaging procedures. You need to check for other imaging procedures, maybe look at other CT scanners, how they actually work before you sort of go into completely using that as a guide. However, I need to emphasize that these are estimates. Once you finish your scan, you can actually do this for the volume that you image. So therefore, that represents a much more sort of accurate value of the patient exposures. So this is just a guide. It's a useful guide. You might be able to do risk-benefit analysis better than if you just use the CTDI volume, because that takes patient size into consideration. So that sort of concludes my presentation today. So if you